We're jumping right into a fascinating yet absolutely deadly biological journey today. We're tracking malaria, from a single mosquito bite at dusk all the way down to a microscopic, systemic cellular invasion inside the human body. It is an incredible and honestly terrifying biological process. But hey, understanding exactly how this invader works, that's the very first step to defeating it. To put the sheer scale of this threat into perspective, just look at this number: hundreds of thousands of lives lost every single year. This microscopic parasite is an absolute global heavyweight. It affects massive populations and demands our constant attention and medical resources. But here's the crucial point I really want you to keep in mind throughout this explainer. It's the silver lining to that incredibly dark statistic. Despite this staggering death toll, malaria is entirely preventable and it's highly treatable. We literally have the tools. And that's exactly why understanding the mechanics of this disease is so vital, so we know exactly how and when to deploy those tools. So here's our clinical dossier for today. We're going to cover the mosquito vector, the parasite's life cycle, the symptoms and severe complications, our diagnostic methods, and finally, treatment and prevention. Basically, we're tracking this chronologically, from the initial bite and stealthy multiplication right through to the clinical symptoms and our medical countermeasures. All right, let's start with Section 1, the mosquito vector, which is essentially a flying delivery system. The whole cascade kicks off when an infected Anopheles mosquito lands on your skin. As it pierces the skin to feed, it releases saliva, and packed inside that saliva is the payload, Plasmodium sporozoites. These are the infectious forms of the parasite, and they get injected straight into your bloodstream, completely bypassing your skin's outer defenses. Talk about a sneak attack, right? Now, we actually face a few different enemies here. There are 5 different species of Plasmodium that infect humans: Vivax, Oval, Malaria, and Knowlesi. But the one you really need to watch out for is Plasmodium falciparum. As you can see, it is by far the deadliest culprit on the list, and it's responsible for the vast majority of severe and fatal cases. Moving right along to Section 2, the parasite's life cycle. This is where the stealthy multiplication happens. Once those sporozoids are in the blood, they make a beeline straight for the liver. During this initial liver stage, or the exoerythrocytic cycle if you want to get technical, the sporozoids invade your liver cells, the hepatocytes, and once they're inside, they pull off this massive cellular heist. They hijack the cell's machinery and silently replicate. Just one single sporozoid multiplies into thousands of new forms called merozoids. This keeps going until the liver cell literally swells up and bursts open, dumping this massive new army right back into your bloodstream. This whole process really highlights the bizarre pacing of the disease. That liver stage we just talked about, it takes anywhere from 7 to 30 days, and it is completely silent, a symptom-free incubation period where the patient has absolutely no idea they're even infected. But the moment those merozoites hit the bloodstream, the pacing shifts violently. You get this explosive, cyclical blood stage attack that repeats every 48 to 72 hours, depending on the specific species of the parasite. So let's zoom in on that blood stage, the erythrocytic cycle. The merozoids flood the bloodstream and instantly invade your red blood cells. Inside, the parasite matures. It goes from a feeding stage called a trophozoite into a dividing mass known as a schizont. Then they violently rupture the red blood cell, releasing a fresh batch of merozoites to infect even more cells. This relentless loop of invasion, multiplication, and rupture, that is exactly what drives the disease forward. Which brings us to Section 3, symptoms and severe complications, the systemic destruction phase. All of those erupting red blood cells cause profound systemic effects. In fact, the synchronized bursting of those cells is precisely what triggers the intense fever spikes you see in malaria patients. And this usually comes with severe chills and heavy sweating, a triad known as the classic malaria paroxysm. Plus, because the parasite is actively destroying red blood cells, patients develop severe anemia. You'll also often see an enlarged spleen as the body desperately tries to filter out all that cellular debris, and jaundice, which is a yellowing of the skin and eyes. But listen, this disease can go from bad to catastrophic really quickly. If left unchecked, the systemic damage escalates rapidly. Severe malaria can affect major organs, essentially shutting down vital systems like the kidneys and the lungs. Once it reaches this stage, we're talking about a strict medical emergency that requires immediate, aggressive intervention. To understand why it's so lethal, you just have to look at the blood flow.
Normal red blood cells are smooth, right? They glide easily through tiny capillaries. But falciparum, it actually alters the infected cells, making them sticky. They start adhering to the blood vessel walls, especially in the brain. This causes massive capillary blockages, starving the brain of oxygen and leading to a highly fatal condition known as cerebral malaria. It's a terrifying mechanical consequence of this biological invasion. That takes us to Section 4, Diagnostic Methods, how we actually find the parasite. Our diagnostic toolkit basically relies on three main methods. The peripheral blood smear is still the absolute gold standard. Doctors look at thick and thin blood films under a microscope to physically see the parasites hiding inside the red blood cells. Then we have RDTs, or rapid diagnostic tests. These use a simple finger prick on a test cassette to show an antigen-antibody reaction, which gives us rapid detection right out in the field. And finally, PCR testing amplifies the parasite's DNA so we can confirm the exact Plasmodium species we're dealing with. Now, alongside hunting for the parasite itself, we rely heavily on supportive laboratory investigations to see how the patient's body is actually holding up. A complete blood count, or CBC, is super critical to spot crashing hemoglobin and low platelet levels. We also run liver function tests and monitor renal function. This gives us a complete, real-time picture of the systemic damage that's occurring inside the patient. Finally, Section 5, Treatment and Prevention. Time for the counterattack. Our pharmacological response depends entirely on the severity of the infection. For uncomplicated cases, we use oral artemisinin-based combination therapies, widely known as ACTs. These are amazing molecules that bind directly to and destroy the parasites living inside the red blood cells. However, severe malaria is an absolute emergency. It demands immediate hospital monitoring and the administration of IV artesunate to rapidly knock down the parasite load before organs start failing. Now, if you recall our list of species from earlier, there's a really important caveat for two of them. If a patient has the Plasmodium vivax or ovale species, just treating the blood isn't enough. We have to prescribe a drug called primaquine. Why? Because these specific species leave behind dormant sleeper cells called hypnozoites that literally hide out in the liver. Primaquine hunts down these liver hypnozoites. If we don't use it, the infection will inevitably relapse months later. But ultimately, as incredible as our pharmacology is, our greatest weapon isn't actually curing the infection. It's stopping the mosquito vector altogether. Prevention is the future defense. We're talking about widely distributing insecticide-treated bed nets and conducting indoor residual spraying to kill the mosquitoes. It includes giving anti-malarial prophylaxis pills to travelers. And, incredibly, we now have a vaccine, the RTSS/AS01 malaria vaccine, which adds a vital new shield to our defensive line. As we wrap up this explainer, I want to leave you with this powerful mantra drawn directly from the source material. It perfectly encapsulates everything we've looked at today. Malaria is preventable, it is treatable, and early action truly saves lives. By understanding the parasite's journey, we empower ourselves to intercept it at literally every single stage. So, the final provocative thought I'll leave you with is this. Since we have the preventative tools to stop the bites, the diagnostics to find the parasite, and the cures to kill it, what is actually stopping us from eradicating malaria forever? Thanks for exploring this with me. Keep questioning and keep learning.